hasa kisababisha chonja. Ewe ndugu yangu we, amka kumekucha, kamata jembe na panga, twende shamba. Hata wewe mwanangu, amka kumekucha, kwani hizi ndizo saa za kwenda shule. Hata wewe karani, amka kumekucha, kwani hizi ndizo saa za kwenda kazi. Uvivu ni adui mkubwa kwa ujenzi wa taifa, kwani ndicho kiini hasa kisababisha chonja. Ewe ndugu yangu we, amka kumekucha, kamata jembe na panga, twende shamba. Hata wewe mwanangu, amka kumekucha, kwani hizi ndizo saa za kwenda shule. Hata wewe karani, amka kumekucha, kwani hizi ndizo saa za kwenda kazi. Chimule. Uvivu ni adui mkubwa kwa ujenzi wa taifa, kwani ndicho kiini hasa kisababisha chonja. Ewe ndugu yangu we, amka kumekucha, kamata jembe na panga, twende shamba. Hata wewe mwanangu, amka kumekucha, kwani hizi ndizo saa za kwenda shule. Hata wewe karani, amka kumekucha, kwani hizi ndizo saa za kwenda kazi. Uvivu ndio adui na ujenzi wa taifa, niepushe na uvivu dada, tujenge taifa. Ndugu yangu kumekucha, amka twende shamba, niepushe na uvivu, tujenge taifa. Wanangwe kucha, amka wende shule, elimu ndio msingi wa maendeleo. Kumekucha, amka wende kazi, na uvivu, tujenge taifa. Asante sana ndugu.
Thank you very much. Good morning, everyone. I would like to invite Edina Talam, the CEO and Registrar of the Nursing Council of Kenya, to open the meeting with a word of prayer. Edina Talam.
God is good, and all the time, God is good, and that is his purpose. Shall we pray? Our Father, in Jesus' name, we come to you this morning with a heart of thanksgiving. We thank you, dear God, for the gift of life. We thank you, dear Father, because you made us as human beings. You've given us purpose in our life. You've given us all the powers and also the knowledge for us to be able to partake what it is. As we stay today in our conference, as we have the deliberation, in repositioning our health workforce, dear God, we want to pray that you may guide us, continue to bless us, and even for those who are traveling, give them safe journey mercies. For all the activities we are going to do, we pray that you may be with us. May you be able to give us favor in our lives and even in the work that you bless us to do. For I pray this in Jesus' name. Amen. And may the grace of our Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with us now and forevermore. Amen.
Thank you, Madam Edina Talam, for leading us in prayers. Honorable delegates, our chief guest this morning, Madam Susan Mochache, the PS for Ministry of Health in Kenya. I would like now to carry brief introductions in terms of countries that are here. We do understand there is a lot of screening outside, and some of the delegates are unable to get in, but I will get in the course of time. So I would like to request the delegates from Botswana to be upstanding. Botswana, Can we appreciate Botswana? Thank you very much, Botswana. Can we, Burundi, the delegates from Burundi, can they be upstanding? Thank you. Can we appreciate Burundi? Egypt, Azel University, are they online or they are here? We appreciate Egypt. Eswatini, thank you, we appreciate Eswatini. Ghana, can we appreciate Ghana? India.
Communities. For those who are not conversant with the EAC is the East African Community, is an intergovernmental organization comprising 6 countries in this region. The republics of Burundi, Kenya, Rwanda, United Republic of Tanzania, Republic of Uganda, and the Republic of South Sudan. So the EAC as a region is home to close to 180 million people. Each country has several health regulatory bodies that shape the training and practice of health professionals. And at the EAC level, these bodies are brought together under the EAC Technical Working Group on Regulation of Health Professionals. And particularly this TWG works with the health professionals to facilitate or to discuss, come up with policy direction on access, facilitating access and quality of health services in the region. So as a matter of introduction, it is good to note that health service delivery in EAC is hampered by a number of factors, including inadequate health infrastructure, shortage of health personnel, and this has already been highlighted by Madam PS, lack of training facilities or inadequate training facilities, absence of ICT-based healthcare information and medical curriculum, unstable communication services, particularly when it comes to e-health service. So the EAC has a number of policy structures and guidance in place. As far as the EAC health policy is concerned, there are enough guidelines highlighting how to strengthen and harmonize training and regulation of human resources in the region. Article 118 and other provisions of the treaty establishing the community, priorities 1 and 3 of the EAC Health Sector Investment Priorities Framework, which is the blueprint for health response in the region, as well as Objective 3 under health, human resources for health under the EAC health policy. So the EAC plays a key role in shaping the curricula, training, and practice of health professionals in the region and in Africa at large. So a number of organs and institutions exist to guide this. We have a number of regional centers of excellence that continue strengthening HRH as well as health infrastructure in this region. So the purpose of our presentation today as EAC is to share our perspectives on how we contribute to health workforce development in the region and highlight the role of the various organs and institutions in addressing the challenges that are facing the human resource capacity for health in the region. At the EAC Secretariat, which sits in Arusha, the role is mainly to coordinate policy and standardize and harmonize training for human resource for health in the region, resource mobilization for health capacity development, coordination of the regulatory authorities in setting standards and enforcing them to ensure quality, monitoring and reporting, curriculum development in some instances, which I shall elaborate later, negotiation of mutual recognition agreements for health workers within the region for mutual recognition so that health workers can work across the region in line with the common market protocol of the EAC that calls for free movement of labor and persons in the region. We do have a number of institutions like East African Health Research Commission that sets the research agenda for guiding training and research in the region. We do also have the Inter-University Council of East Africa, of which all the member countries in the EAC are represented, which is in charge of curriculum development, harmonization, resource mobilization, as well as negotiating the mutual recognition agreements. At the EAC level, we have the East African Science and Technology Commission in charge of curriculum development, harmonization as well, and setting guidelines on practice and capacity development. So the regional approach in terms of supporting human resource for health in the region, the EAC has been doing a lot of work to contribute to the relevant support for high-skilled workforce in the region. We do have in place a number of institutions, particularly the regional centers of excellence. One of the regional centers of excellence is the East African Center of Excellence for Oncology, which is based in the Republic of Uganda. We do have the East African Center of Excellence in Biomedical Engineering, e-health, and health rehabilitation services in the Republic of Rwanda. The EAC Regional Center of Excellence for Vaccine, Immunization, and Health Supply Chain Management in the Republic of Rwanda. EAC Center of Excellence for Nutrition Sciences in the Republic of Burundi. The EAC Center for Excellence for Nephrology and Urology in the Republic of Kenya. The EAC Center of Training on Nursing based at Aga Khan Hospital, and the EAC Center of Excellence for Cardiovascular Sciences. So these institutions have contributed in terms of providing training in a number of areas, including masters in urology and renal medicine, fellowship in clinical nephrology and pediatric nephrology, masters in biomedical engineering, e-health and rehabilitation, and mobility sciences, as well as training in certificates for supply chain management. Majority of the programs are conducted at certificate and diploma level. The super specialized training is still very low at about 5% in PhD, masters, and fellowship programs. All countries under the regional centers of excellence are expected to have a kind of mutual reciprocation of students so that each of the specialized regional centers of excellence is able to reach out to the different health cadres that it specializes in training from all the countries in the region. So in terms of coordinating regional initiatives, the centers of excellence have received funding from a number of donors, including the German government, in terms of grants and loans to ensure that they coordinate the training of these specialized health workers in the region. In terms of curriculum development, the EAC is indirectly involved to address key challenges, including training of staff in mobile laboratory science, especially in the advent, if I can say so, of the pandemic. We have faced a lot of challenges in terms of ensuring testing, access to testing services in the region, and the EAC mobile service program, mobile laboratory program has facilitated, or is even continually facilitating, the training of officers to ensure that the mobile labs deployed in all the countries are able to reach out to as many people as possible, facilitate testing, in a bid to combat the spread of the virus. We have at ESC proposed influence the curriculum development of short courses and in pandemic preparedness under the One Health approach, which has been approved and currently being undertaken and spearheaded by the Egerton University. So as you can see from this presentation, the ESC has contributed in large part towards training of health workers in the region to ensure that there's a wide pool of expertise to address the key health challenges that we are facing as a region. But besides that, there are guidelines that have been set by the institution to facilitate ensuring that all the countries, especially the medical and dental schools, adhere to standards and certain high standards and guidelines in training. And to ensure that this is adhered to, the ESC convenes on a regular basis inspection of medical and dental schools to ensure that they adhere to these set guidelines and standards and therefore promote harmonization of education and training in the community in line again with the common market protocol that guides, that provides for free movement of goods, persons and labor in the region. So the ESC, as you can see, has created a framework for harmonization of health worker training in the region to ensure that the set standards are adhered to and that any health worker that is educated or is trained in this region is able to reach out and provide services everywhere in the ESC. So in terms of challenges, as Madam
Alison,
yes?
Wrap it up.
Okay. Yeah, a number of challenges include inadequate resources. Of course, that's common across Africa. Poor linkages in terms of collaboration. Weak reporting structures have hindered a success in terms of availability of human resource for health. But in terms of next steps as a region, one of the key things that we are promoting is ensuring that the nursing boards and councils and allied health professionals who have been left behind in terms of harmonization and training and practice are brought on board to strengthening further the issue of the health workforce in the region, as well as strengthening of health training institutions, which has been a challenge that has been observed in the region. One of the most successful strategies, of course, is partnership and exchange learning among the various countries in the region, but also across the continent. I would like to take this opportunity to thank you for listening to me. I'm still available later to continue discussing, and I hope we shall enrich this discussion together. Thank you very much.
Thank you, Alison. I think Alison deserves a round of applause for really painting a clear picture on the role that the ESC plays when it comes to the harmonization of curricula and training. Thank you, Alison, for sharing insights when it comes to the East African health policy, particularly focusing on the HR arm. All the insights that you've shared will be instrumental as our discussants share their experiences. As Alison concluded, she talked about the role of nursing councils when it comes to the harmonization of health curricula for our health workforce. And you highlighted that one of the next steps and one of the key challenges that you're focusing on as an East African community body is then stepping up the role that nursing councils play. And so this provides a good segue for us to hear from the chair of the Nursing Council in Kenya, Eunice Karibu. Share with us your insights when it comes to the role that cross-border recognition agreements play for medical specialists, as well as the role of joint inspection in medical facilities. Karibu, Eunice.
Thank you very much, Madam Cass. First, I want to thank everyone, and particularly the inclusion of nursing in the conversation about health workforce, because clearly we know the role nurses play, particularly in ensuring that we are able to attain universal health coverage. Going back to my experience, particularly around the ESC and mutual recognition and harmonization, In my role as Dean of Aga Khan University, we have previously attempted to have harmonization both of the nursing and midwifery curriculum in terms of training, but also in terms of regulation. And I know that effort never really bore fruit, and the conversations around this harmonization have resurfaced. And I know it's one of the things that KfW, that's the German bank, is looking forward to funding. In my own experience, one of the challenges that we find when it comes to harmonization is that we are not able to maximize on the opportunity that arises, particularly for student mobility and faculty mobility. In my own experience, particularly working through the three countries of Kenya, Uganda, and Tanzania, is that we have a rich, vast experience of particularly the faculty who are available to train, but also of clinical sites and clinical teaching experiences. If we talk about palliative care, for instance, Uganda has a really good palliative care, landscape. So opportunities to maximize also on clinical sites experiences and placements also come to the fore. I think the other thing that is also critical is the idea of continuous professional education. The reality is we can't teach everything in a classroom. So once our healthcare workforce is out there, it is important then that we provide them with opportunities for continuous professional education. And this can happen in any of the other countries that we have in the EAC block. So if you're looking at where should investments go in particular, I think one of the key areas is around getting the nursing and midwifery councils together to think through what should that curriculum look like and how should the licensure and regulation look like. So that if a nurse is trained in Kenya, they don't have to go through loops and hoops to actually get accredited in Uganda or Tanzania and vice versa. The second element that I think needs focus is the entry behavior of our students. As long as we have different entry criteria in different countries, then we really can't have a conversation around harmonization of curriculum, because it means the entry behavior is different, the expectations are different. So that's yet another conversation that needs to be had, and that's a larger conversation that involves the regulators beyond the Nursing and Midwifery Council, but actually the higher education. That briefly is my comment. Thank you very much.
Thank you, Eunice. I think she again deserves a round of applause. Eunice brings out key aspects, particularly on the role of bringing together the different nursing councils for them to be able to have those pertinent discussions. I particularly support her when it comes to the idea of ensuring we have at least a harmonized criteria when it comes to entry requirements for our students. I think what we can do now is segue into Uganda. Eunice did mention that Uganda has one good center of excellence that touches on palliative care. And so Joel, kindly share with us your insights. What is the role of cross-border recognition agreements for medical specialists? And what is the role of joint inspection of medical facilities at the cross-border section? Karibu, Joel.
Can I use this?
Yes, please.
Good morning again. As I said, I'm Joel Okolo. I'm the chairman of the Uganda Medical and Dental Practitioners Council. The views I'm going to share, I've received permissions from my fellow chairpersons from Kenya, Tanzania, Rwanda, Burundi, and South Sudan. If they have any objections, please can you raise your hand? If you don't, then you'll accept what I'm going to say. I think the starting point in all this and the success of the role of the regional economic bodies starts from a very high level. The high level was set by the presidents of these states. And if you have that level of commitment, it makes the rest of the work easy, because through that, there's a flow down of instructions from the presidents to the ministers of health, to the PSS, to the regulatory bodies, to the deans, to the teachers, and so on. So all this is made possible because of the great commitment by the heads of states. When the heads of states met in 2013, they did realize that one of the areas of cooperation is in the area of health. And we did realize that we have got a serious human resource for health crisis. We are talking of a population of about 100 180 million people. And if you look at the doctor-patient ratios, which sometimes is a bit skewed because it doesn't tell you what is happening to the other health professionals. But if you look at the professionals' density per 10,000 persons, this brings out into reality what we are facing as a zone in the area of provision of health services. Now, having realized that, then we are saying, are we going to get there? And that is where the regulatory bodies came in. The regulatory bodies came in because one of our major assignments is that we should be able to set standards and ensure that the first point was, what is the kind of doctor we want? I'm sorry, I'm going to talk from a very skewed angle that is about doctors because that's where we have been working. I know there's been some work in the nursing field as well. So what is the kind of doctor that we want? That was our first assignment, to define the doctor that we want. What qualities, what competencies, and so on. So we are talking about a doctor. And if that is our definition of the doctor that we want, what are the competencies? So we went ahead and designed those competencies. Then we said, how then are we going to train these doctors? And if they are going to be acceptable across the borders, because that was one of the protocols on health, that they should be reciprocal registration. Design, what we really did was to harmonize, because there are already curricula for medical training in all the partner states. And that was not an easy thing to do. We are not curriculum experts, but we took what we had and we developed what is called the core curriculum. I'm not going to discuss what the meaning of a curriculum is, but in that curriculum, we talked about what are the minimum qualifications that they should have, who is going to train them, and what is the content is going to be like, what are the methods of training, and importantly, what is the method of assessment, and how are we going to use what we find to improve the curriculum. That has been the task of the dental and medical councils in the East African region. To enable us to do that, we then had to develop checklists that we used to go to the various medical schools in the region. And in the region right now, we have got 30 medical schools and 5 dental schools. And then we use this checklist to go and check, do they have a curriculum? Do they have training staff? Do they have infrastructure? Do they have the finances? What is the system of evaluation of the candidates? And what sort of products are we getting out? And this really has been a major role that the medical and dental councils in the region has been playing. And at the beginning, it wasn't easy because there was a lot of misunderstanding of what is this that we are talking about. Do we want to remove the autonomy of the universities as far as training is concerned? So we had to overcome some of those hurdles. But I'm glad to say that slowly we are getting there and we are beginning to see results. Of course, there are still quite a number of challenges. Challenges just about understanding the roles, challenging about what type of training methods we are going to use, challenges about the number that we are producing. Remember what the PS said, although we need an increase in the number of health professionals, it's not just about numbers, it's about qualities. And one of our roles is how can we instill quality in the products that we are going to get so that they are recognized across the borders and also that they are marketable, not just within the region, but the world over. That is a tall order, and that is what we are trying to solve in the coming years. Thank you.
Thank you. Thank you, Joel. Again, a round of applause for Joel. Thank you for highlighting particularly the journey that you've gone through as a Ugandan Medical Council in trying to look at how we can actually have the mutual recognition of specialists across the region. Joel highlighted key challenges that they are facing within that structure, Challenges that touch on infrastructure, challenges that touch on financing, challenges that touch on ensuring that standards are met across the border. At this juncture, I'd like to invite the Director General, Ministry of Health, Kenya, to share his experiences and to particularly touch on the issue of cross-border inspection of medical facilities. How can we standardize the infrastructure? Joel has been able to highlight that that is a challenge area. How can we ensure training faculty are at the same level of training and numbers? How can we ensure that the staff that are recruited meet the specified educational standards? Karibu DG.
Thank you, moderator. First, I'll start by giving us small background on the health relationship between the health workforce and the health economy. Health workforce is a critical player in health service delivery. That is not in any doubt. But surprisingly, as we sit here today, there are 1 billion persons in the entire planet who never come into contact with any healthcare worker throughout their entire life. That is astonishing in the 21st century. That out of a population of close to 8.3 billion people, 1 billion people go through their entire life course without interacting with the health workforce. Healthcare workers play a critical role in healthcare service delivery, and they form a very important part of the health economy in terms of production of healthcare services and also utilization of healthcare services. Not only as producers, but they're also consumers of the same health service that they produce. The UN High-Level Committee on Economic Growth and Employment, for example, in 2015, indicated that by 2030, the health economy is going to create 120 million jobs. But on the flip side, there'll also be a shortage of 18 million healthcare workers. 50% of these will be in Sub-Saharan Africa. So Sub-Saharan Africa and Southeast Asia will have a shortage of close to 9 million healthcare workers. So even as we train, we must, at the back of our mind, we know that we have a huge gap to be able to fill. And directly, the health economy creates for every one job that a healthcare worker creates. Indirectly, there are 3 jobs that come because of the people who are in the supply chain, and indirectly because of the improved health of the population, and of course, more resources available in people's pocket, and therefore, that spurs economic prosperity and economic growth. In the same 2015 indicators, the health economy was able to produce 10% of the global GDP, which is about $7.3 trillion, a huge amount of money. But that does not take cognizance of indirect products of the health economy, like sports, nutrition products, social care, like if a healthcare worker goes to see somebody who has stroke at home. So you can be able to see how big this healthcare economy is. And the principal driver of the healthcare economy is the healthcare worker. So the more we invest in the healthcare worker, the more we are going to ensure better economic growth. And one unique thing about the health economy is that it is one economy where 2/3 of the players are women. If you compare that with the general economy where the ratio is about 40% women, 60% men, in the health economy, it is 60% plus women. So that brings about the issue of equity. So we get more women involved in the economy, we have more peace, the 5 Ps, prosperity, peace, the people, partnerships, and a better planet for all of us. So we need to continue to invest in the health economy through recruitment of healthcare workers to ensure that we have global sustainability because of the critical role that women are going to play as the key drivers of the health workforce. We are also undergoing an epidemiological transition. All of us, the colleagues from the East African Community region, the rest of Sub-Saharan Africa, many of our countries are reporting increased burden of non-communicable diseases. And for us, unfortunately, most of our people get the NCDs at a younger age, meaning they'll require longer-term care. This is a big challenge to us in terms of achieving UHC, because more people will be required to be able to offer services for our population who suffer from NCDs over a longer period of time. And because of increased life expectancy and because of advancement in medicine, even if you suffer stroke, it is possible that they require long-term rehabilitative care, which is a big, big challenge to low-middle-income countries. And therefore, it is not only important for us to train the high-level healthcare workers. For us to be able to achieve universal health coverage, we must go back to the ground and embrace primary healthcare. When we are talking of cross-border training, cross-border recognition, we should start from the very, very bottom so that we have community healthcare workers who can be able to deal with this increasing burden of non-communicable diseases, together with what we still have, the communicable diseases, of course, and the occasional devastating pandemics like what we are experiencing today. So even as we are trying to train, let's not only talk of training at that very high level of top specialists, doctors, nurses, but let's also train together as a region, the East African Community region, a strong team of community healthcare workers who can be able to ensure that we achieve universal health coverage through the primary healthcare approach, with emphasis on health prevention, health promotion, and a strong community partnership. It is important for us, of course, develop standards, uniform standards for us as a region to ensure that a doctor who has been trained in Burundi can easily come to work in Kenya, because that free movement of labor is what the world is interconnected. Even if you want to put barriers across to be able to protect your local labor force, from Kenya. Then I move across to Malaba or to Isebania or to Namanga, and then I'm told I need to have another PCR. If we are to walk this journey together, it means that whatever we have agreed on, we must implement to the fullest. And it is important for us to be able to do that, as has been clearly shown during this pandemic, of how barriers that we put because of protecting, purportedly to protect our people, have caused more harm than good. When you insist on that, there's a backlog of trucks from wherever country X to country Y. Goods traders lose lots of money in the process. Therefore, if we are to recognize the doctor, let us recognize the nurse, but let us also recognize the results that has been done from an accredited facility within the region.
I think that deserves a round of applause in this age of COVID-19 pandemic.
And of course, for global health security, it's important for us to be able to establish and enhance our pandemic intelligence so that we can be able to scan our environment and see where challenges are emerging, uniqueness of cases of particular disease coming from a particular point. Should be able to raise our antenna a notch higher so that we can be able to quickly share that information with our partner states so that we can be able to mount a common response plan to be able to protect our population. Because in the foreseeable future, pandemics will be the order of the day. I thank you.
Thank you. Thank you, DG. A round of applause for DG. And so now now we're coming to the end of our session, and as I sanitize this, we've spoken about healthcare workers for the past 30 minutes. We need to hear from the healthcare workers in the room. And so with a roaming microphone, if there's a healthcare worker in the room, we would like to get your insights on the role that East African community plays in shaping the curricula, training, and practice of yourselves. Do we have a healthcare worker in the room, a practicing healthcare worker? There we go. Could we have a microphone for that gentleman right there? Or could you stand up and perhaps come to the front and share your insights? There's a microphone behind you. And as he comes to the front, I would like to appreciate the DG for recognizing the role of women in the health professionals. And so the next speaker requires to be a woman who will share her insights as a health provider. Karibu.
Thank you very much. So, my name is Wycliffe Ogenya, and I'm representing CHESOA, which is an association for community health. The speakers have mainly talked about doctors, nurses, and we are talking about healthcare professionals. So I think there's need for more emphasis, especially when it comes to the communities. We have the community health volunteers. We have what now we are calling universal health coverage. So I think as we talk about standardization, as we talk about harmonization, as we talk about training, there should all be more emphasis, especially at the lower level. Otherwise, most of the conditions we are talking about, like the NCDs, if people are not screened at the community level, if the community health volunteers are not able to screen and be able to refer these people at the earliest opportunities, then we'll meet here maybe in the next 30 years and the discussion will be the same. So we would want, maybe do, I don't know whether we call it an affirmative action, so that more emphasis should be on preventive as opposed to curative. So that is what I wanted to submit. That's my observation. So
thank you. Can we appreciate him for raising comments on the role of preventive care and, of course, the crucial role that community health workers play in the achievement of universal health coverage. He has already given us our first call to action of this conference, that can we recognize the role that community health workers play in achieving the UHC dream. I see somebody waving to me there. I still don't see a female. I'm going to be biased. Thank you, ma'am. Let's start with the woman.
Thank you, Madam CAS. And I really have enjoyed the speakers after you. I represent Kenya Association of Clinical Pathologists. I'm Professor Emily Rogena from Jomo Kenyatta University of Agriculture and Technology. My comment is on the centers of excellence. That is perfect. The pillars that have been put by the East African community are excellent. But my comment is on evidence-based medicine. As we move along with specialization, we need to have serious investments in diagnostics. And each time people talk about oncology, renal medicine, evidence that proves that is left behind. No wonder the DG has problems with standards in diagnostics across. And so our proposal is that we move along with evidence and we move along with, through the region, perfecting the evidence. Thank you.
Thank you, Dr. Rogena. I must say that was my teacher for pathology, and she didn't score me too well. No wonder we don't have harmonized standards in diagnostics. Thank you, Mwalimu. Let me have one last comment from that gentleman, and then we'll wrap it up with a vote of thanks, just because we are running short of time. But this is a continued discussion throughout the day and for the next 2.5 days. Karibu.
Thank you very much. Excellent presentations. They make sense. It's common sense. I just realized that the pharmacist was not mentioned at all. Once you diagnose a patient, The nurse will use medication, the doctor will use medication, everyone will use medication. And for some reason, that is not highlighted. The cost of healthcare, if you look at the percentage of the cost of healthcare that goes to medication and medication management and medication errors, it's 20 to 40%. I stand to be corrected, but it's around that figure. So the thing is, it's important for the pharmacist, who's a drug expert that everyone will use to provide care to everybody else, is involved and is also is a pillar in this issue. So I am a pharmacist. I am the I am the CEO of PSK, Pharmaceutical Society of Kenya, and I think the pharmacists need to be given a moment.
Thank you for those comments. And this is exactly why we have this platform today, to be able to really pull out the issues that touch on all the different cadres in the health sector, and to ensure that we're all harmonized, particularly in terms of our curricula and training, towards the attainment of universal health coverage. I would like to thank my panelists today for sharing their experiences with us. I would like to thank you all for paying attention and for contributing to this discussion. I would like to thank those who are joining us online as well for their contributions towards this discussion. As we come to the end, I would like to invite Joel, who will give a vote of thanks on behalf of the panelists as we proceed to the second panel of the day. Karibu, Joel.
Yes, good morning, I'm back again. I'd like to take this opportunity really to thank our moderator and my fellow panelists for giving freely of their time and their views to this conference. I would like to say and express a lot of gratitude to Kenya Medical and Dental Practitioners Council, who has been in the driving seat in many of the activities that we have done in this region as a body. We'd like to appreciate them and the great work that they are doing. I'd also like to take notice of my fellow regulators from the African region, a body that brings us together called AMCOA. And in our midst, we have got our president of AMCOA, that's Let Lape from South Africa. And he is also the chairman of a body that brings us all together under an international umbrella, that is IAMRA, International Medical Regulatory Bodies of International. Can you say it again? He will say it for us when he comes. But I would also like to recognize the different economic blocks. I don't think it was an accident that we invited people from the ECOWAS as well as from SADC, because we would like to hear from them what they might be doing in their areas in order to promote harmonization of training in their regions. I have a dream that one day a Ugandan will be able to walk from Kampala to Durban and get registered and get practicing. I'd like to see a day when one Kenyan will be able to walk from Kisumu and go and practice in Ibadan without any restrictions. I believe that time is coming, and I'm sure it will come within my lifetime. Thank you. Have a great conference.
Thank you, Joel, and thank you for sharing your dream with us. I think that is a shared dream, the dream of ensuring that we do have harmonization of the curricula and training and practice of health professionals, not only in the East African community, not only in the African country, but as a global agenda. Asanteni. My panelists, we can now leave the dais. Thank you.
Thank you. Wow.
That is on the transformation of health professionals, university curricula for achievement of UHC. And our speaker is going to be Professor Grace Njoroge. She's from Kenya. Professor, karibu sana. This is going to be moderated by Dr. Rashid Aman. He's the Chief Administrative Secretary, Ministry of Health. Welcome, Dr. Rashid. Please give them a hand.
Good morning, everyone. Let me once again, on behalf of the ministry, welcome all of you to this very important conference. And I can see that there's quite a bit of excitement. The panel that we have just concluded has laid the ground for us on issues that we need to discuss and focus on. We are now getting into the nitty-gritties, and I'm sure that this will also be discussed through the sessions, the breakaway sessions that the program has set up. Human resources for health is perhaps the most critical building block of the health systems. It is one of the health systems, I want to remind ourselves, and that all the other blocks of the health system are there because they are all needed and work together. Some of these blocks will have health professionals who will specialize in those particular areas. And therefore, as we discuss human resources for health, and I think the issue was raised by one of the speakers from the floor, that we need to recognize human resources for health is varied and diverse, is hierarchical, and that we need to keep this in mind. The health systems work together when we succeed in working as teams. Healthcare service delivery works well when we work as teams, different cadres, different health professionals, bringing their experiences together for the benefit of the patient. In this session, our speaker is going to give us a glimpse on curricula for training of health professionals. We heard that as we talk about health, human resource for health, we have the numbers to consider, we have the curricula to consider. What is it that we're training our health professionals on? What is the content and substance of what we are training on them on? Has it been static over the years, or have we been doing piecemeal transformations? We are talking about transformational change. If we need transformational change, then we need a very serious review of the content that we train our health professionals on, how we prepare them for the future. The world has changed over the years. COVID-19 pandemic and other pandemics have taught us a lot. We are on journeys to achieve universal health coverage, and we have recognized where our gaps are. So we need to look at that very seriously, review those curricula, come up with a curriculum that is fit for purpose, as has been said. Often, when we are trained in university, or at least when I was trained during my time, I know that we went through the formal courses, but when you go out there into the real world, there is another form of learning that you have to undertake. On-the-job learning that you need to undertake. Technology has changed. Those soft skills that we learn on the job perhaps now need to be mainstreamed into the curricula. Perhaps we need to think about that and see how we can mainstream some of these. And even as we go out and learn on the job, we need to formalize that. We need to formalize that in a way that graduates will go through a program that will enable them to perform better in their jobs. Communication skills, the digital space, all of these are challenges that we need to face. I would like now to invite our next guest, who is a specialist in this area of curricula. Professor Grace is a professor at the Jomo Kenyatta University of Agriculture and Technology. She has a strong educational background. She is currently the Deputy CEO of the Commission of University Education, and she's in charge of accreditation of curricula for universities. So I think it will be very exciting to hear what she has to say about curricula, how they assess the curricula, what criteria is used for accrediting these curricula. Please, let me welcome Professor Grace to come and share her experiences. Thank you.
Good morning, ladies and gentlemen, all protocols observed. It's my great pleasure to do this presentation. And before I do it, allow me to recognize our leaders in the Ministry of Education who are here. We have our PS, Ambassador Nabukwesi, who is in charge of university education. We have CEOs of the various agencies in the Ministry of Education, including my own CEO, Professor Mwenda Ntarangwi, who is in the house. Professor Mwenda, with whom I have consulted in preparing this presentation. I have a PowerPoint, which I hope is available for our viewers who are here physically and those who are online. We want to look at the whole idea of the curriculum for university education, especially as we consider matters of harmonization and achievement of the universal health care as a quality assurance institution, which the Commission for University Education is. I want to briefly discuss with us the matter of the role that the Commission for University Education does play in accreditation, in quality assurance, quality auditing, curriculum reviews, and as well as think through the whole matter of what exactly do we need to think through in terms of being more relevant in our training for health workforce in our nation and beyond. I will also be looking at some of the key messages that we have received as we have talked with our key stakeholders in the area of training for health, with special reference to the universal health care. And lastly, I'll give a general bit on recommendations as we think about harmonizing training for health professionals in our region and beyond. I just want to bring out from this slide that we are established as a state agency that is expected to quality assure from an external perspective of the quality of university education, training, research, and innovation. And one of the things that concerns us, for example, is whether the curriculum that universities are rolling out does respond to the needs of the sector for which they are training. We use a peer review system whereby we have tools that we use for accreditation, for review, and even auditing that curriculum and institutions. And among that approach or peer review is that we ensure that in our processes, we involve the experts that are in that field. In the case of training for the health workforce, we have a pool of experts in the various disciplines of health that support the process. As I proceed, I want to just bring out in this forum that the matter of relevance is so serious in our country that it is enshrined in our own constitution, that universities need to have programs that are not just of quality, but it does respond to the needs of the sector. I don't know whether my remote is working or not working. Yes, it's working. So as we engage universities as an external quality assurance agency, we are careful to know that the universities themselves have internal quality assurance mechanism, and so we use our tools that we have provided for minimum standards that meet the threshold, that help us to establish if the threshold for quality and relevance has been met. And of very special significance in this meeting is the fact that we are very keen to ensure if a curriculum is being developed or if a review of a curriculum is being brought to our attention, including the harmonization of curriculum that we are talking in this conference, we want to be sure that there is sufficient needs assessment. And I want to encourage us in this forum that as we think about harmonizing and transforming the curriculum so that it responds to achievement of universal health coverage, that there is sufficient engagement so that the need is completely and well established for all. We expect that the target industry, whoever we are targeting, has been consulted sufficiently, and above all, that the inputs have been put in place. And as we continue, we are asking ourselves as a external quality assurance agency if the health professional training would be transformed for a better achievement of universal health coverage. What would that direction be? And what would inform this? We are keen to note that the Sustainable Development Goals are engagement for all of us, but we are talking more of goal number 3, where the universal coverage is enshrined. We are careful to also note that that the achievement of UHC is multi-directional. We in training have our part. Those in practice have their part. But we want to be very keen that we are consistent with a global strategy that has been in place for a while, which has put training for health, training for achievement of universal health coverage as a key milestone. And the support for training of our universities, for example, in medical education becomes a key focus as we think of achievement of universal health coverage. So training in the universities, therefore, is central among other levels of training that are in place. I want to bring us to speed on where we are at, for example, in accreditation of institutions and curriculum that is supporting our medical education in Kenya, but also bring a special note that as an accrediting agency in our country, with the accreditation councils and commissions in the region, and with the help of the support from the Inter-University Council for East Africa, we have developed a harmonized criteria for accreditation of institutions and curriculum across the East African community. For Kenya, I wish to report that the country has invested greatly in the establishment of universities and university colleges that train in health matters. And it is interesting to note that of the 76 institutions in our country, that is universities, and 50% of at least a program or a number built in the area of workforce for health. Kindly note that over 63% of the 38 institutions that are training in health are actually public institutions. These are directly funded by government, and although the 14 out of 38 are private, we also have government funding for students in health who are studying in private institutions. That is in as far as institutions are concerned. We also have curriculum that is in place that contribute directly or indirectly in matters of training health professionals. And I wanted to bring to our attention that these are not few. Over 495 programs in all our universities are contributing to development of health workers in our country. In terms of enrollment, we'll find that we have a very significant number of students in our universities that are actually training in the field. I have put the matter of computing and ICT deliberately because previously these were not considered very directly related to training health professionals. But with the advancement of technology, with matters of emergencies, for example, the COVID situation that we have had, we do realize how much ICT and computing is contributing either directly in the teaching and learning, that is e-learning, but also there is a lot of technological advancement in the area of health that we need to begin to bring on board in training our health professionals. I want to bring some very clear messages that have come out as we have looked at literature on what has been happening in the area of UHC and reviews of curriculum that have informed better achievement of UHC milestone. And I just want to begin this by just noting that achievement of UHC is really an international commitment, especially the recognition that primary health care needs to be a very key component in our training, even in universities, if we would want to facilitate better achievement of universal health care. I want to bring some of the experiences that we have put together as we have asked ourselves the question of if we are harmonizing university training for health professionals, if we are transforming it so that we are better placed in achieving this milestone, what are some of the examples and benchmarks do we have? I've just pulled out just a few countries in Africa and outside Africa where we have learned as part of our engagement on how best to accredit, how best to think about curriculum reviews as we go towards 2030 and beyond. And one of the interesting examples that we have come across is the one from South Africa, where it is very clear that they had to restructure their medical schools. And one of the key focus in their curriculum was to focus on the local medical needs of the region. It was interesting to note that they had to go towards more community-based approach and primary health care by ensuring that their students, even the universities, have an exposure to community experience, but an interesting policy direction that I thought was very interesting was that when their students did graduate, they had a one-year experience that was mandatory for the graduates. And I thought this is an experience to share with us as we think about harmonizing, accelerating, or having a curriculum that helps us to accelerate achievement of UHC. How much experience should our training look like when we are training and probably as the graduates leave the universities? I was impressed about the Japanese experience, for example, whereby they had to come up with what they are calling the CBME, the competence-based medical education. And for them, one of the key needs they had is the aging population, for example, who had medical needs that the trainees needed to be very vast about. And they found that by making it community-based in its approach, they were producing graduates that were more conversant with the matters of comprehensive care. Allow me to bring the other experience that maybe most Kenyans probably would be very conversant with. We have had medical professionals coming from Cuba. But again, from the literature that we have, it is interesting to note that for them to accelerate the UHC achievement, they needed to rethink the curriculum, transform the curriculum in such a way that about 75 to 80% in the training was done in community facilities. A very interesting example whereby the country had to accredit polyclinics which would serve as an extended training facility for their medical students so that they are more in touch with the community they were going to serve, as opposed to it needed a policy direction at a national level. But the important thing was that this curriculum, in as far as Cuban literature that is available for Cuban approach, does indicate that they have a more mobile, more dynamic approach to their medical training curriculum, so that whatever needs are in the community are reported as part of their evaluation, and that involves or informs the changes that needed to be done. As I continue this discussion, I bring the notice that part of our engagement with stakeholders between 2018 and to date, and we continue, has been how, for example, we are going to transit university education from the current curriculum in Kenya to the competence-based curriculum. And one of the stakeholders that we had was a team of professors from the University of Nottingham in the UK, and we did have a lot of discussion around their CBC, but the matter of training medical professionals in a more broad way to meet the health needs of the UK became a very interesting indication for us, especially when this conference came up. These discussions we had through a program that we were doing together, and we were able to understand that for their pharmacists, and I think there's somebody who asked something about pharmacists, they have transformed their curriculum so that they've been able to incorporate much more into the pharmacy curriculum so that they are able to have a multidisciplinarian pharmacist who is better prepared in handling the patients, discussing with patients, and also getting involved, not just in the drug dispensing, but also a lot more, even in the actual training. Allow me to bring some messages that have come up as we have also talked to some of the experts, those that are training in our universities, those that are practicing in the health sector in our country, and we're asking them, do you, in your best considered opinion, feel that the curriculum in our universities across board, I'm thinking of medicine, dentistry, nursing, pharmacy, all of them across the board, we've just scanned through some of the messages, and I want to bring to the attention that we've also looked at the curriculum that the Commission for University Education is hosting, because once we approve a curriculum, we also retain copies in our library, just to inform ourselves whether there is a message for now as we think about achievement of UHC and by 2030 and actually beyond 2030. And some of the messages, as you would see in this slide, would look like most of the training, the curriculum that we have needs to bring out more clearly and in-depth matters of primary health care. This point too, no, this is, I have 5 minutes, thank you. I wanted to bring back the slide. this slide, but allow me just to mention that one of the responses that I found very interesting was from some practicing medics who indicate that the area of community and public health in training our professionals is too brief. The feeling is that even the rotations that they do does not equip them or give them sufficient experience in the matter of community and public health. The other comment that I felt I needed to share in this forum is the understanding from those who are practicing that the approach that is curative in nature, it's too strong at the expense of the preventive approach in training. So as we think about harmonization of curriculum, as we think of transforming for achievement of UHC, the matter of balance between the two is called for. The other one is that the courses that would bring, we are done? Okay. Okay. The matter of courses that have to do with public and community health appear too late in the curriculum, and they need to be spread and have a little more of them early in the years of training so that there is better experiences for our students. And I think this slide has been here long enough. I just want to say that the other response that we got is that there is too much of specializations too early, and we need to be cognizant of that fact. Thank you. So in terms of recommendation, I had a recommendation that we need a national policy to guide in transforming and even harmonizing this training for better achievement of UHC. The Commission for University Education is well prepared to receive and to guide the process, because it's a process of curriculum review. It's a process that will require quality assurance. And we thank you very much. We continue the discussion in the interest of time. Thank you very much.
Thank you, Professor. Let's give her a round of applause. And sorry, our apologies for cutting you short, because we are running out of time, I am informed. And we also have one more session to cover before the opening session. I would now take the pleasure in inviting His Excellency Governor Anyang' Nyong'o to come over to the podium and make his remarks. Thank you. You want me still to be here? I am excused. Okay. How are you? Karibu, Karibu. Professor, thank you very much. I'm really sorry that the time was, I think the time was not on your side.
Good morning, ladies and gentlemen. Can you stand up and try and get some freedom? Hey, hey, I feel all right. 1, 2, Hi, Ketini. Asanteni sana. I thought some of you were beginning to sleep, so as a teacher, I need to wake you up. Sawa sawa. Asanteni sana. Well, I'm expected to speak rather briefly this morning to you about service delivery and the health workforce from a devolved system governance perspective in Kenya. This morning you have heard all kinds of descriptions and analysis about the workforce from various perspectives, local and regional. And as Marx once said, philosophers have described the world in various ways. The point, however, is to change it. So with what has been said this morning, what are we in counties changing the situation so that we can deliver healthcare better, in the nation of Kenya. Since the adoption of the devolved system of governance, whose success is anchored on its performance and service delivery, we have learned critical lessons that should inform our actions as we position today's health workforce to face the future. The Kenyan health system has evolved significantly over the last 10 years. Our capacity to manage communicable diseases and avert deaths has improved. Investments in health have increased consistently in absolute terms across all health system strengthening domains, and demands from citizens for accountable and responsive health services have increased. I wish, therefore, this morning, especially talk about what all this implies in terms of human resources needs. The future of healthcare, though uncertain, can be predicted. The effectiveness in delivery of health services will continue to be heavily dependent on well-trained, adequately deployed and distributed workforce. County governments have made significant investments and registered great success in building the capacity of their health workforce. A critical pillar in increasing access to quality health services and improving the health of all Kenyans. This is one of the areas in which substantial progress has been made in bridging of the equity gap in access to health services across the county and the counties. Before devolution, there was huge disparity in distribution of health workers across the country, driven mainly by distribution of health facilities, as you have seen in the presentation this morning, disease patterns and allocation mechanisms. Counties such as Mandera, Wajir, Tana River, Samburu, Turkana, and Nandi scored low on standard ratios of health workers to the population. Now, this we could see from Dr. Mott's presentation this morning in terms of the global Kenyan figures. On the other hand, areas such as Nairobi, Machakos, Mombasa, Kiambu, and Uasin Gishu had better ratios, but still below the requirements prescribed by the World Health Organization. Disparity across the cadres were more prominent before devolution than we have today. Out of approximately 56,000 health workers serving under the county governments, 44.6% are nurses, 5.5% are doctors and medical specialists, 6.3% are medical laboratory technicians, while only 1.7% are community health workers, and 0.17% are health promotion officers. From that distribution, you will learn one thing, that although we are laying a lot of emphasis, as has been said this morning, on primary health care and family health, we only consign 0.17% and 1.7% of community health workers, and those health workers engaged in promotive health. That ratio must be revisited. County governments have enhanced linkages between health workload data and staffing, and the role of the county public service boards in this effort is commendable. As we get into the next cycle of development of county integrated development planning, CIDP, there is a need for more rigorous analysis for better program design. This calls for the review of the distribution of health workers in both national and county governments with closer integration and interrogation of cadres and levels of care. The review should be extended to the private sector as we establish the primary health networks for supporting the implementation of the universal health care. Okay, well, this is not my fault, that's yours. Health workers account for the highest number of staff at county and the highest current investment for counties. 32.9% of county government budgets were allocated to health workers in the financial year 2020-2021. transfers of staff undertaken at the commencement of devolution, as well as rationalization efforts, have had to be intricately balanced with labor relations. There is an urgent need for the operationalization of a framework for facilitating inter-county transfers. Admittedly, there has been a great emphasis by county governments in the first 2 terms of government on filling in the heavy gaps that existed before devolution, not forgetting that significant resources had to be dedicated to bridging infrastructure and equipment gaps too. However, there is heightened attention by county governments to other critical issues, such as supportive supervision, retention strategies such as recruitment of KMT students from underserved areas in a bid to have them return and serve their communities, revitalizing the community health units and focus in service and postgraduate sponsorships. Management of transition to devolved governance has not been devoid of conflicts in resource allocation. Protracted delays in the passage of division of revenue bill, fluctuation in conditional grants allocation, especially for county level 5 facilities, significant allocation resources for functions assigned to county governments, to the national government, recruitment and management of health workers under short-term contracts, notwithstanding several health worker strikes coordinated nationally and in specific counties. KMTC expanded campuses to enhance equity, with the county government in some cases providing core contributions in formal land. Whilst these gains are significant, county governments have also experienced hurdles, especially in the following key areas. 1, bearing disproportionate burden paying for salaries of doctors, undertaking for training institutions, persistent staff absenteeism resulting from their participation in capacity building activities coordinated by national Ministry of Health departments. Well, ladies and gentlemen, we shall take a short break until His Excellency opens the conference, and then I'll come back. Makofi kwangu basi. You don't thank me, you thank me later. I haven't finished. So go ahead with other programs. Thank you.
Another round of applause for the governor. Thank you very much. Again, our apologies for cutting this short. I understand we are now preparing to clear the room, and Mr. Yumbia is here to give further direction.
Thank you, Honorable Nyongo, the governor, and CAS Rashid. In-house keeping protocols that needs to be taken, that we are now required to to proceed for tea, which is served in this tent. You are kindly requested to carry your conference bag with you. This is point number 1. Point number 2 is that the tea will be taken for exactly, it's for Untitled, it's a health break for exactly 15 minutes. So at 11:15, we are supposed to be seated. If you find your seating arrangement has been changed, don't complain. Please comply, because that other program has other protocols that must be followed. Point number 3 is that there are 3 groups of people who are required. The Conference Planning Committee. The Conference Planning Committee. Please see Kasmwanganki before His Excellency finishes his speech. The other group is AMCOA Management Committee. See Sadika. And then the heads of delegations. The heads of delegations from specific countries that are here. You'll see Dr. Amoth. so that we can give you directions on where to be positioned. Heads of delegations, each particular country, the ministers who are here. So we need to do that, and therefore, you are now free for tea for 15 minutes. Please move with your bag this way. Do not get out of the enclosed area, because coming in is restricted. So you are only here. There are washrooms at the back. You are free to move out. Thank you. Yes.
Can we appreciate the Selfied Band? Thank you for the coastal tunes. Thank you, Maxwell, with your team. I would like to announce to us that our chief guest is already within the premises. Any time from now, our program will commence officially. I would like to welcome each and everyone into this program, the official opening of this conference, the Health Workers Curriculum Conference 2022. We are on standby. I can see the Kenya Police Band ready, and on my left, I can see the KPA Choir ready to lead us into the national anthem and the East African anthem. When that time comes, I'll kindly ask all of us to be upstanding as His Excellency the President will be making his way into the auditorium. For now, continue listening to wonderful tunes. The band, the Celsius Band, led by Maxwell, the director.
Hongera ewe rais wetu na viongozi kwa jumla kwa huduma zenu tunasonga mbele mbele kwa ujenzi wa taifa. Hongera ewe rais wetu na viongozi kwa jumla kwa huduma zenu nchini. Tunasonga mbele mbele kwa ujenzi wa taifa. Huduma zako ni muhimu nchini Afrika Mashariki na Kati. Tunasonga mbele mbele kwa ujenzi wa taifa. Huduma zako ni muhimu nchini Afrika Mashariki na Kati. Tunasonga mbele mbele kwa ujenzi wa taifa. Hongera ewe rais wetu na viongozi kwa jumla kwa huduma zenu nchini. Tunasonga mbele mbele wa taifa. Hongera ewe viongozi kwa jumla kwa huduma zenu nchini. Mbele kwa ujenzi wa taifa. Furaha kwa wakina mama wote nchini, umeboresha sekta ya afya. Tunasonga mbele mbele kwa ujenzi wa taifa. Furaha kwa wakina mama wote, songa mbele mbele kwa ujenzi wa taifa. Tuna viongozi kwa jumla kwa huduma zini. Tunasonga mbele mbele kwa ujenzi wa tisi wetu na viongozi kwa jumla kwa huduma zenu nchini. Tunasonga mbele mbele kwa ujenzi. Ya leo kwa ajili ya mwamko mpya, tunasema ni asante kwa rais wetu wa Jamhuri ya Kenya. Tunashukuru madaktari wetu kwa kazi nzuri mnayofanya kutupatia huduma inayofaa. Na tunahamasisha pia vijana wenzetu wale mlioko katika sekta hii ya afya, tujitume kama waanzilishi. Hongera, hongera, hongera raisi wetu, hongera kwa kazi nzuri. Hongera raisi, hongera raisi wetu, hongera, hongera, hongera raisi wetu, hongera na Wakenya wote. Hongera raisi wetu, hongera, hongera raisi wetu, hongera na Wakenya wote. Hongera huduma zenu nchini. Tunasonga mbele. Hongera ewe rais wetu na viongozi kwa jumla kwa huduma zenu nchini. Tunasonga mbele. Simba we hatuzoeani, ni heri urudi nyumbani. Nyumbani kwenu ni mwituni. Simba fikiria kwa makini, lililokuleta mjini. Wataka kunila na mimi, wataka kunila na mimi. Simba we una shukurani. Raki na Kongoni wakuchezea na uwaoni, ulivyoanza kula majani nikakuimba. Una nini kichwa mwitu gani? Simba una nini kichwani? Unasahau ya mwituni na ukinila hata mimi utaingia mwitu gani? Timba niseme lugha gani? Sasa yapata miaka 10, bado wanguruma kwa ndani, hali mwituni unatamani. Umeshanitoka manani, sijui nikufanye nini, sijui nikufanye nini. Simba we una shukurani, Simba una nini kichwani? Umesahau ya mwituni na ukinila hata mimi utaingia mwitu gani? Simba una nini hata mimi utaingia. Simba nili hizo kucha ni za mwituni, tutazikata karibuni kichwani. Hujasahau ya mwituni na ukinila hata mimi utaingia. Hujasahau ya mwituni na ukinila hata mimi utaingia mwitu gani? Simba una nini kichwani? Hujasahau ya.
Let us not tire to appreciate the band. Another round of applause. Asante sana. I would like to take you on the other side of the stage where there is the Kenya Police Band. Of His Excellency the President, he will, on a guided, he will go to view a few exhibitions which have been arranged out there, not more than 3, so we can have Police Band giving us some numbers. Thank you, Police Band. At the same time, I would like to recall Burundi. We have Egypt, who are watching us online. We have who are other assistants. We have Korea, who are
Maendeleo ni umoja na kuelewana sisi sote wazalendo na kuelewana sisi sote wazalendo na amani kwa utulivu na umoja kati yetu tujitahidi kujenga Kenya yetu. Kwa hivyo twawasihi wazalendo upendo na amani kwa utulivu na umoja kati yetu tujitahidi kujenga Kenya yetu. Nguzo maendeleo ni umoja na kuelewana sisi sote wazalendo. Nguzo maendeleo ni umoja na kuelewana sisi sote wazalendo na kuelewana sisi sote wazalendo. Tangu jadi tumeishi kwa utulivu na kuzingatia maadili ya kijamii. Umoja wetu uliotuwezesha kunyakua uhuru wa nchi yetu tunauheshimu. Tangu jadi tumeishi kwa utulivu na kuzingatia maadili ya kijamii. Umoja wetu uliotuwezesha kunyakua uhuru wa nchi yetu tunauheshimu. Nguzo maendeleo ni umoja na kuelewana sisi sote wazalendo. Nguzo maendeleo ni umoja na kuelewana sisi sote wazalendo na kuelewana sisi sote wazalendo. Nguzo yote wazalendo. Nguzo maendeleo ni umoja na kuelewana sisi sote wazalendo na kuelewana sisi sote
Thank you for Nguzo ni kuelewana. I would like the choir, if you can take your seats for just a few minutes as I welcome the Saleswind Band to give us some interlude of music as we are nearing the main program.
Guests from different countries represented here. We want to say jambo jambo. Yeah. Hakuna matata. Hakuna matata.
Jambo, jambo bwana, habari gani? Nzuri sana. Wageni wakaribishwa Kenya yetu, hakuna matata.
Let's sing together.
Jambo, jambo bwana, habari gani? Nzuri sana. Wageni wakaribishwa Kenya yetu, hakuna matata. Jambo, jambo bwana, habari gani? Nzuri sana. Wageni wakaribishwa Kenya yetu, hakuna matata. Tuimbe sote. Jambo, jambo bwana, habari gani? Nzuri sana. Wageni wakaribishwa Kenya yetu, hakuna matata.
Kenya hakuna matata. A country of peace,
Jambo rafiki, habari gani? Mzuri sana, tuimbe, tucheze sote. Kiswahili ni lugha ya taifa. Jambo bwana, habari gani? Nzuri sana, wageni wakaribishwa. Kenya yetu hakuna matata, Kenya nchi nzuri, hakuna matata. Yote mwakaribishwa, hakuna matata. Watu wote Kenya, hakuna matata. Kila siku, hakuna matata. Jambo rafiki, hakuna. Watu wote Kenya, hakuna matata.
Thank you, Selsun Band. Thank you.
Hakuna matata.
Thank you. Thank you. Thank you. We are now on standby. His Excellency, the President has been taken on a guided tour as he's viewing a few exhibitions out there, and then he will join us. Just hold there. As you can see on the screens, His Excellency is being guided as he is viewing a few exhibitions before he joins us here. this official opening of... May I request that you remain standing. Standing as I invite the opening prayers from Mohamud Sheba, Imam Shibu Mosque here in Mombasa.
Ya Allah, we are here to witness the occasion of the official opening of this important, what you can say, health, and we have a president, His Excellency President Uhuru Muigai Kenyatta, to grace the occasion. We are so happy. We pray for him and his government to continue leading us as Kenyans and to make us very happy. And for the visitors, you're most welcome in Kenya. Karibuni sana. Thank you very much.
Your Excellency, ladies and gentlemen, kindly be seated. Your Excellency, the President of the Republic of Kenya, Uhuru Kenyatta, the Chair, Council of Governors, and all governors present, and elected leaders present, Heads, Excellencies, the ambassadors, and the heads of missions. With your gracious permission, allow me to invite.
First of all, to recognize the President, we have Governor Anyang' Sanga from Siaya County, Governor from Nyeri County, Governor Tunai, the County. Your Excellency, I have a very simple duty today. As medical tourism.
Care services cannot be realized instantly. Responsibility as the leadership of the country to make sure that every Kenyan citizen enjoys the highest quality standard of health care. For county government, health remains a high priority in our development agenda. I therefore want to take this opportunity to thank the conference organizers for organizing a very important conference which aims at harmonizing the curriculum and training of health and care professionals. The expected benefits: 1, enhancement of skills of our health professionals. 2, eventual realization of the agenda. 3, quality and adequate training of our health professionals. 4, equipping health professionals and workers with the necessary skills to meet workplace challenges by equipping them with a new complement. At this juncture, let me briefly address the way forward in the face of driving challenges facing health professionals, increase the quantity of health workers, but also address issues of quality and relevance. Across Aruka, the counties, they continue to experience an imbalance in skills mix of health professionals. 2, health personnel must be lifelong learners, able to adapt to rapidly changing environment and keep abreast of the latest scientific and technological advances. The health personnel must also be change agents. And in conclusion, therefore, I want to express conference organizers for working closely with the county government through the Council of Governors to plan for this conference. The expected outcome of this international conference will definitely attract strong political commitment government and with the intent to improve healthcare, professionals, education. I thank you for listening to me. God bless you. Asante sana.
Thank you, duty and great honor to invite Dr. Gosi Letlape to give us some highlights of the conference for just a few minutes before we continue.
This is the first conference that I attend internationally post-COVID. And what COVID has shown us is that our health systems are near collapse and they need to be rebuilt. What we will also remember about COVID is George Floyd, with Chauvin having his knee on his neck. And in health, George Floyd represents the ordinary citizens in the continent. Chauvin and his knee represents all of us in this marquee. The regulators, the university people, the lawmakers. We make laws and we build health systems that we are not prepared to use for ourselves. When we get sick, we get flown out. We, the healthcare leaders, we, the politicians, we get flown out. And that is what COVID has underlined. So we hope this conference will begin to bring us to the right path. Firstly, we need to define the future that we speak of. I hope we will not be building systems for the past. We're going to build systems that we will go to for our own healthcare, so that we do not have to fly out and we use the cadres that we define for the ordinary people. In my country, if you're ordinary and you have a brain tumor, you'll be seen by a community health worker. If you're affluent and you have a hangover, you'll be seen by a neurosurgeon with a physician in attendance. And that needs to change. Our continent is characterized by a subconscious manifestation of self-hate. And we need to love ourselves. So whatever cadres we trade, we must trade for our own personal health care. It can no longer be the lowly for the low, because then we have assumed the mantle of being the colonizers of our own people. If there's an area that exposes that Africa is not free, it's in our health systems. Apartheid is apparent. We have colloquials, Mr. President, where when we talk about the communities, we're not talking about ourselves. When we're talking about public health, we're not talking about ourselves. We're talking about private health for us, or medical tourism, whether it's in Russia or it's in India. It is time we build systems that we will use. You know, in my culture, there's a norm that when you've set a table, you eat first. As we set this health table, we should go there for our own health care. I was saddened in 2009 when a young colleague in a regional hospital was stabbed by a mentally disturbed patient in a public hospital. And there were frantic attempts, Mr. President, to rush him to a private setting, and he died in the process. So he was in a teaching hospital that takes interns that could not manage a stab wound. That's what we have created. And I say to you, colleagues across disciplines, let us restore professionalism. Let us tell those that say we are lesser people by asking us to shift tasks, that is our past. Professionalism so that we can build healthcare teams, even our heads of state. I'm heartened, Mr. President, that you are wearing a Cuban shirt. And I will leave you with the example of Fidel Castro, who built a healthcare system that he used. When he got colon cancer, he wasn't flown out of Cuba. He stayed in Cuba. He went to the same facilities that ordinary people go to. He shared hospital bed with ordinary people. He lived for an extra 10 years from the treatment given to him by his people. If he flew to the States, he would have got expensive treatment. There would have been a bill of over $1 million, and he would have to be his remains would have had to be repatriated to Cuba at a greater cost than the cost of taking him for treatment. It is time, Mr. President, that the medical profession leads. It is time that we ask for resources. In the previous session, we spoke about producing quality healthcare so that it can be exported internationally. We now need to train for our own needs. As we train people that are internationally marketable and recognized, we have a duty to ensure that home is an enabling environment for them to practice their profession. God has endowed us with a beautiful continent, beautiful weather. Why should, after the training, at the tax expense of the worker in Africa, should I go and I hope we will stop talking and we'll have an action plan where, in memory of George Floyd, it is not Black Lives Matter. It is all lives matter.
Thank you very much, Dr. Kosi Letlape. Your Excellency, now I welcome you to view a video on a statement by the Director General, World Health Organization, Dr. Tedros. To the videos.
Your Excellency, President Uhuru Kenyatta, President of Kenya, Honorable Mutahi Kagwe, Cabinet Secretary for Health, Honorable George Magoha, Cabinet Secretary for Education, Excellencies, dear colleagues and friends. Jambo, thank you for the invitation to speak to you today. And I'm sorry I can't be with you in person. I offer my deep admiration and respect to all of Kenya's health and care workers for their tireless service and sacrifice, especially in the past 2 years of the pandemic. And I offer my deep commitment that WHO will continue to support you in any way we can to suppress transmission, save lives. The privilege of meeting President Kenyatta in Nairobi shortly after he announced that affordable health care would be one of 4 pillars for his second term in office. He asked me to help his government to identify the best financing model to achieve his vision. Less than 12 months later, I had the honor of joining President Kenyatta in Kisumu to launch Kenya's pilot project on universal health coverage. COVID-19 is a powerful demonstration of the importance of health and care workers as part of every country's journey toward this universal health coverage and for health security. The pandemic demonstrates how critical health workers are and why they need the investment, the decent jobs, and the most up-to-date information, competencies, and tools to keep their communities healthy and safe. Ensuring a fit-for-purpose health workforce is not just a matter of the number of health workers, but ensuring they have the education, training, lifelong learning, and the equipment they need to do their jobs safely. That means curriculum updates and a competency-based education model that's aligned with the health needs of populations. The ministry's ongoing health labor market assessment will provide important evidence for this work, and WHO is committed to supporting you at all 3 levels. In the coming months, WHO will publish new evidence and guidance on competency-based education to support your national dialogue. Last year, we also broke ground on the WHO Academy, which aims to transform lifelong learning for health impact globally. Using state-of-the-art learning technologies and advancements in learning science, the Academy will expand worldwide access to the highest quality learning for health workers around the world. It will deliver multilingual, personalized learning programs in digital, in-person, and blended formats, and it will go beyond the transfer of knowledge to building the competencies of millions of people including health workers, managers, educators, ministries of health, and the general public. Your Excellency, Mr. President, Excellencies, last month, WHO held its executive board meeting, chaired by one of Kenya's finest, Dr. Patrick Amoth. Patrick, thank you for your leadership. In my opening address to that meeting, I set out the challenges the world faces: disruption to essential health services, the urgent need to roll out vaccination against COVID-19, especially in Africa, and the impact of the pandemic on progress towards universal health coverage. Addressing these challenges requires a well-trained and properly supported health workforce. The pandemic has reminded all of us that there is no health without health workers. Health and care workers have done so much to protect us. Now, we must protect them. I thank you. Asante sana.
Asante sana. Your Excellency, it is now my privilege and great honor to invite the Cabinet Secretary for Health, Senator Honorable Mutahi Kagwe, to make his address and also invite you to address the gathering.
Your Excellency, Uhuru Muigai Kenyatta, President of the Republic of Kenya, colleagues in cabinet, colleagues in leadership, ladies and gentlemen. First, Your Excellency, before I make any remarks, I want to confirm that this meeting here today is shared by two institutions within your government, and that is the Ministry of Health and the Ministry of Education. I would therefore like to yield to my elder brother, the Honorable C.S. Magoha, to first say a few words before I make my own remarks. C.S. Karibu.
Oh, Your Excellency, the President, distinguished ladies and gentlemen, I have conflict of interest because, as you know, I'm a medic, and I was succeeded by Dr. Letlapi, who has just addressed you, and I was also succeeded by the current chair of the Kenya Medical Practitioners Dentists Council, Dr. Ivan Jenga. So allow me to address myself in those two capacities very quickly, that what we are doing here, from the medical practitioner's point of view, has already been in place, especially in the East African region. As chair of the board then, we worked with all the East African community countries and regulated their hospitals and medical practitioners to the extent that their curricula were more or less streamlined. But what is more important now from the Kenyan perspective is that His Excellency saw some worth in me, and I was brought to look after primary and secondary education. And I can now see the link between the competency-based curriculum and CBET to what we are doing at the university level. And therefore, I hope that as you address issues in this conference, you will tease out, because I have now known that you can start teaching a child in primary school about the beating heart. You don't have to wait until that child goes to secondary school. And therefore, it's going to be very interesting to start interesting children in medicine, in pharmacy, as they start mixing substances in primary school. And therefore, those who still do not believe that competency-based curriculum is real, I am told that my colleagues in Amkoa, with whom where I was president for a while, are all here. This competency-based curriculum is working in many African countries. And let us not politicize it and support His Excellency the President's drive that we move forward in that direction. To Your Excellency the President, I want to confirm that you have led our country. You have put out health issues first. It is just unfortunate that our people do not recognize the successes that they have had. COVID has ravaged many developed countries. As I speak to you, Your Excellency, ladies and gentlemen, COVID has not even killed 6,000 people in this continent. It is not by accident. It is because of our healthcare facilities. So we must also start, as my colleague says, that we should accept what is African. Let us first of all clap for ourselves for having systems that work. And since it is not my day, Your Excellency, I want to leave it there just by ending by saying that we also recognize the First Lady for the work that she has done, especially for the Linda Mama phenomenon. Whether anybody likes it or not, Your Excellency, you shall be remembered because universal health care is one of your pillars. And what you have done can be measured. Forget about the raw toxic politics. We don't belong there. When you are not there, it shall be recorded that this is what you have done, and we have made strides. Just to end and say that over the past 15 years or so, even for universities teaching medicine, we have gone up 500%, and therefore there is need to further harmonize the curriculum. Thank you very much, my brother, for giving me the opportunity.
Thank you very much, my brother, C.S. Magoha. Your Excellency, I want first to start to appreciate that this day has come as a result of a lot of hard work and cooperation that has been done not just nationally, but also internationally. I want to take this opportunity to say a special thank you to the team from the Ministry of Health that has made this day possible. In that regard, Your Excellency, we had a huge task force led by, co-chaired by Kas Mwangangi and Eva Jenga. Between the two of them, they shared a big team that we at the Ministry of Health, myself, the PS, the DG, all supported to make sure that it is working. And a special mention also to Yumbia, who was KYM, as he likes to call himself, KYM for the team. Your Excellency, I want first to recognize also the presence of very important partners who we work with all the time, because without their support, we would not actually be successful in the area of health. I want to say, to recognize the presence of my friend and brother Atwoli. Karibu sana, Secretary General Wakotu, kwa sababu he is a key supporter of the Ministry of Health, and his workers are the ones we work for. He represents them, and I keep on teasing him that I represent them as well. Only he gets paid by them, I don't. So, karibu sana, Bwana Atwoli. I also want to recognize, Your Excellency, the presence of two persons in this hall who are also very, very key to our success. One of them is the Honorable Sabina Chege. I don't know whether Sabina Chege is here. The Honorable Sabina Chege, who is the chair of the Health Committee of the National Assembly, and the Honorable Bito. I don't know whether Bito is here. You are representing him. Yes, who is the chair of the Health Committee of the Senate. It is through the committees that are represented by those two individuals here, Your Excellency, that we managed to pass the National Health Insurance Fund. And that is the key. It is one of the key pillars as far as universal health coverage is concerned. But today, sir, we are here to look at another subject, which is part of the three things within the UHC agenda. The first being affordable health care, the second being access to health, which we have been talking about, and through your political will, we have managed to create almost 25 hospitals in Nairobi, 19 new, 5 engineered and completed, and another 50 that we are building across the country to create the issue, to address the matter of access to health. But critically is the standards of health, not just the quantity of health, but also the quality, of health. And today, sir, this is the subject that brings us here together. We work on this subject with a lot of other partners who are here. We work with USAID. We work with the British High Commission. We work with other development partners who are represented here, World Health Organization, the World Bank, and other institutions that are represented here to ensure that we can upgrade the quality of healthcare. Your Excellency, when we talk about the curriculum, improving our curriculum, we are reminded of an African saying that says, when the sound of the drum beat changes, then the dancer must also adapt the step. Things have changed around us, Your Excellency. The world has moved on. In technology terms, the world has gone very far. We cannot afford to be left behind. We were left behind because of gunpowder as a continent. And I appreciate the remarks by my brother from South Africa. This time round, technology is one of the key aspects in terms of digital health and all the other aspects that we are going to address. We are going to ask ourselves many questions, sir. We are going to ask ourselves, is what we are learning today what we should be learning? Is what we are learning today what is being taught elsewhere in the world? Is what we are learning today sufficient for the future? And is what we are learning today equivalent or better than anything else they have out there on earth? Because God created the human body to be exactly the same. Whether it is in Greenland, whether it is in South America, South Africa, East Africa, whether it is in Asia, the human body is essentially the same. So the question, Your Excellency, that we are going to ask ourselves is, why should one body be treated better, have a better opportunity of being treated than another body? And we are convinced that the questions we are going to ask here and provide answers and debate throughout the next 3 days are going to be useful as far as learning how to deal with our future as well as our present is concerned. Your Excellency, you have led us from the front. You have given us everything that we would require. I want to say here and now that there is nothing we have asked for from Your Excellency that you have not said, go ahead and do it. And to answer my brother from South Africa, and at the point of perhaps embarrassing my brother Joho, Governor Joho, Your Excellency, I arrived here 2 days ago, and when we went to PGH, Governor Joho was within the hospital, but I didn't see him when I came and I was asking where he is. He walked in a few minutes later and told me that he was actually observing his own father being treated with the new equipment at PGH. So what my brother is saying about our own enlightened self-interest, that we in leadership must provide what we ourselves can consume, and we must provide a standard that we know that we will not be shifting elsewhere. As you saw, Your Excellency, at the stand today from KU, Chair Olive explained to you that going forward, we do not need to go to India for treatment. We will do it here. But the question is, of course, whether we will have the caliber of persons, the doctors, the engineers, biomedical engineers that we need to ensure that not only do we treat Kenyans, but we also cater for those who may want to come to our country for treatment. Therefore, sir, without much ado, I just want to take this opportunity to thank you specifically for the support that you have given us, but also to thank everybody in this hall and those listening. 26 countries are represented here. Over 90 people who are in this hall come from other parts of the world, and we appreciate your presence here in Kenya. I know the governor did not invite you to tour, so I'm going to do it on his behalf. that don't plan to go home quickly, plan to stay in Mombasa for a little while. So, Your Excellency, it is now my distinguished pleasure to invite you to speak to Kenyans, Your Excellency, and to spell out the vision that you have, because really what we are implementing is your vision, is your agenda, and we are proud to be associated with it. Welcome, Your Excellency. Please stand up to welcome His Excellency.
Oh, sorry. Please be seated. Thank you very much.
Thank you, sir.
Governor Joho, Governor of the County of Mombasa, who's hosting this conference, and your colleague governors, ministers present, all our gallant medical practitioners who are here, distinguished ladies and gentlemen. Let me begin by saying how truly delighted I am to join you on this occasion, an occasion attended by so many distinguished professionals, men and women who have spent their careers charged with the wellness of the 25 nations represented here today. And also today we are privileged to be joined by policymakers, public thinkers from the entire spectrum of our nation's life as we reflect on the future of our medical training, while we host this first biannual conference on harmonization of curriculum for training of our health professionals. The world has been engulfed in a crisis occasioned by COVID-19, which has caused unprecedented disruptions across many sectors of our society. Arising from this pandemic, we know our medical professionals and healthcare workers across our country, our region, and the world over have had to bear unusually heavy burdens. Indeed, through the tireless efforts of our healthcare workers, the pandemic has largely been brought to the fore the pivotal role that you play in providing quality healthcare and contributing to the general well-being of our societies. Therefore, as nations of the world join the global quest to achieve the Sustainable Development Goal number 3 of ensuring healthy lives and promoting the well-being of all, we are challenged to reassess the training framework for those who bear the first level responsibility in the delivery of healthcare. In that regard, this conference could not have come at a better time. Indeed, it marks a turning point in our national quest to achieve universal health coverage. Each epoch of our nation has placed a unique set of demands on the skills and competencies needed in the workplace, which in turn has required us to reform and to recalibrate the content and architecture of the training we provide our healthcare workers. Today, I note with satisfaction that the conference will review key planks that can lead us closer to harmonization of the curriculum for health professionals training. And it is in this context that I invite you now to join me as we take stock and reflect and learn, and in particular, plan for the transformative changes that governments should adopt in the training curricula for healthcare professionals. I cannot overemphasize that this conference has the task of providing a trustworthy account of the quality of our healthcare training. That account must give us a picture of what has worked and what has not, and the reasons why. The primary purpose here is to tease out lessons learned as well as best practices. But more fundamentally, we must ask ourselves, given the lessons learned, what transformative changes should we adopt, and do we have mechanisms of ensuring that these changes are optimally implemented? I therefore would like to propose a 7-point framework to all of you participants today. And this framework can guide us in understanding our performance and charting the way forward. This 7-point framework that I am proposing includes, first, defining a framework for harmonization of training of healthcare professionals across the sector for increased global competitiveness and future job readiness. Under this theme, the conference should on one hand consider how we can leverage on regional frameworks to harmonize curriculum and training to support cross-border training and practice. In addition, the conference should identify the gaps in elementary teaching and learning which ought to be addressed to ensure that a solid foundation is established before healthcare workers undergo their academic and professional training. Moreover, the conference should consider how the capacity of tertiary education, technical and medical training institutions can be augmented to effectively deliver quality healthcare training. The second is determining strategies to strengthen generation and use of research, innovation, evidence, and technology to inform policy and practice for increased access to health services. Under this theme, the conference should consider how the adoption of innovative and technology-driven mechanisms that are educative and informative in training of healthcare professionals can bring our nation closer to the realization of this objective. The third is establishing strategies for health workforce optimization through planning and forecasting. The fourth is to provide a framework for reimagining entrepreneurship and innovation opportunities for the health workforce towards increasing absorption of the same. The fifth is defining effective mechanisms for cross-sectoral partnerships and collaborations towards re-engineering the health workforce. Sixth is formulating necessary policy and regulatory frameworks to support strengthened training, development, and deployment of health workers in line with changing health needs. The seventh, enhancing governance in cadre recognition, schemes of service, and scope of practice for improved health workforce management and retention. So, ladies and gentlemen, as I conclude, I would like to state that I am persuaded that the consideration by this conference of this 7-point framework would enable us to deliver a trustworthy account of where we are on the overall quality of training for our health professionals. But more importantly, the questions will tease out lessons that will guide our future planning and herald a much-needed harmonization of training for all our healthcare professionals. So, ladies and gentlemen, let me say that we are all keenly looking forward to the outcomes of this conference, which I trust and believe will be useful to us as policymakers to be able to ensure that we are able to deliver, as our friend here has said, the kind of health care to our people that we ourselves would also seek to enjoy. And I do believe that here in Kenya we are making those strides. We may not yet fully be there, but we are definitely moving in the right direction. Talking to Olive Mugenda over at Kenyatta University, it is great satisfaction to hear that the recently opened molecular institution there at KU has now treated over 200 patients, almost 20 patients every day, patients who would have been forced to travel to India for the same. It is even more satisfying to note that we are also receiving patients from across the region who are coming for that same service. Tomorrow we will be with Governor Joho, opening a similar institution here in Mombasa. If we just take those 200 patients alone and assume the cost to India for treatment, upkeep is taken into account, even if we just take it at 2 million shillings, that's 400 million shillings that have been saved and a cost that is covered under the National Hospital Insurance Fund. That is saving direct to the pocket of ordinary men and women in this country. It is also heartening to note that in some of our hospitals today, private hospitals are referring their patients to some of the public hospitals because some of our public hospitals are even better equipped than some of the private hospitals that we have had. And what does all this investment mean? It means that if we continue to improve these services, we save this country money, we save our people money, which can be put to other use. We know how health has bankrupted many families, many families, because there is nothing you can do. But now we are beginning to provide those alternatives. And what we must make sure is that we have the caliber of professional health worker that is able, operating within the environment we are providing in upgrading our hospitals, that we have trained men and women who can utilize this equipment and provide the best healthcare systems comparable to any part in the world. And I'm sure we can. Because again, as our friend has said, Canada, the United Kingdom, Australia, they wouldn't be here trying to get our nurses to go and work in their hospitals if we were not producing good quality people. We are producing. What we need is to ensure that the skills they have are equivalent to the kind of technology, as Waziri has been saying here, that is available out there. And they in turn will be able to provide our people with the same level of service as they are capable of delivering out there. Kwa hivyo, wenzangu, jameni saa ingine muache kujipiga. Tumesonga. Na story ya watu huko kupepeta huko kwa mikutano kuongea mauongo huko haiwezi badilisha ya. Let you here to help us, tell us here we can do better, here we can do better, here we. Mama ni namna gani wenzangu? Kazi inafanywa huko hospitali. Nasa endi huko kusimama kupiga mtu. Unajua mimi leo nimefanya, anaingia IC sana.
Thank you. Tumpigie mheshimiwa makofi. Asante sana mheshimiwa Rais. Asante sana mheshimiwa Rais. Let us give another round of applause to His Excellency the President. Thank you. May I request that we be seated for a while. Kindly let us take our seats as I invite the chair and the co-chair, Dr. Mercy Mwangangi, and your co-chair, to make a presentation to the President. Your Excellency, they are going to make a presentation of a gift. They are going to gift you because out of your tight schedule, you have found time to come to open this conference. Your Excellency, they are going to present you with a plaque. The plaque is showcasing the various projects and programs undertaken in delivering the universal health care in this country. Tumpigie makofi Mheshimiwa Rais tena. Making the presentation on behalf of the organizing committee is the chair and the co-chair. The chair, Dr. Mercy Mwangangi, who is the CAS, and Dr. Evelyn, who is the co-chair. Let us not tire. Another round of applause as they take that photo. Thank you. I request for 1 minute, Your Excellency, as we sit for 1 minute as I make this very special announcement for the photos which we are going to do out there. You'll be escorted by the protocol team, all the heads of the delegations who present, the conference committee chairs, and the AMCOA management committee, and the conference secretariat, all those committees to lead to where we are going to have a photo session. And at the same time, I've been asked to announce that lunch will be served at the main restaurant at the hotel. Your Excellency, with your 1 minute, that 1 minute as the policeman takes their position, it is the children who are making steps for the future, the Huruma Town kids with a medical display as we are on standby for the national anthem.
Bill, yank that sucker so we can get out of here.
No, the appendix hasn't burst. That's good news. Slippery little fellow.
Did you guys know this is my first surgery with Dr. Bell?
No kidding. We have to get a photo.
Kitty and Chew.
That is totally inappropriate. Go back to your stations.
Oh, we're just having fun. He's out cold all night, huh?
Wait, I'm gonna take a quick selfie. Get closer together.
I wish we could do one without the mask.
Quick, let me chew. Just one more. I think we got it. I'm going to send this to my mother.
Camera's on the lounge door. He's waking up. I need to up the placebo.
Oh my god. You did artery? On an appendectomy?
You're losing blood fast. 2 liters of normal saline wide open. Call for 4 units of blood and 2 FFP stat. Give me your number. Sure, I'm starting compression.
Let the training begin. Ladies and gentlemen, welcome to the Health Workers Conference 2022. Repositioning today's health workforce for the future.
Let us give them a round of applause as we all stand up. Let us all be upstanding for the closing national anthem. Thank you. Now, His Excellency will leave at his own pleasure. And the rest of us who are proceeding to the photo session area, let us hasten our steps so that we can continue with the photo session. Thank you.
Kwako mimi napenda kwako mimi napenda. Nimekuwa msanii. Ameka live. Oh. Chika kumbe. Tunaenda sisi kutafuta nini huku, then we are going home. Na mimi sikupata maji.
Haukupata maji? Ya ukweli?
Serious?
Naweza nikupe maji.
Hii siwezi kupa, yani haiwezi toka kwa hii mkono yangu. Oh, good morning. It's afternoon already. Uko sawa? Niko sawa.
Kuna media center pale juu. You can come and chill when you want to rest. Then lunch inaserviwa kwa tent ya blue.
Kwa tent ya blue.
So you guys can go for lunch.
Interview somewhere, naenda kucheck briefing. Natafanya briefing mali. Nikuhoji, nakuja.
Kwa na shida zangu. Umekuwa na mbili.
Ameniambia nitakucheck.
Sawa, acha akacheck basi. Yes.
Walinyonga interview.
Walinyonga lakini kapambana hivyo.
Kama ni moja basi kuna NDA. Hata stream maji.
Hapana. Iko chini hapo tunaweza ongezea.
Atajipanga basi. Nataka kuongea. Sasa huko wakimidel tutakuwa watanifuata. For now wewe deal na iko pia atakuwa na
iko sawa kila kitu.
Kwa amenipea kila kitu. Tuna record ina kadi. Kata na record ni kadi.
Niko nazo. So kaza na unasaidia kwa nini kukata?
Sawa. Ndio tuende tuna mwanzo kuweka tu na.
Tunachukua tripod moja mute. Makutano, faraja na baraza.
Hiyo ni gani?
Hii ndio hii ndio iko sawa. Sasa chini kwa makutano which are really just.
Sasa hivi
mpaka majogo.
Bahari na baraza. Sasa niende bahari ama baraza.
Leo watu wako lunch bado. Breakout sessions. Mecha mkiwa kuseta. Leo tunaona. Hiyo kitu na complain. Inasema. Hiyo kwa ngoni ni. Nina record
Network inaziwa kabla.
Sasa unapita nje ikiwa. Pale breaker zenyu hazina AC. Paulo, shika. Paul, Paulo, do hivi. Hata hizi kamera ziko. Hata pressure. Unaona hapa kamera. Pangeni. Hapa. Chukua kamera yako moja NX. Ya kwa twende na hata nipatia bila wewe. Hakuna kamera mbili hapo. Naenda nazo nasema kila ndio kuna key. Ndio kuna key. Kwa kamera moja. Kamera moja. Unapokutumia moja. Si ndio unaona? Sawa, hata nione. Wakatana kama hapa. Kama niambie. Tumia moja. Breakup ni 4. Ama ngoja Ken come. Ndio kuna kamera 8. Azizi kuna kamera 8 wapi? Kamera ni 7. Check kamera ni 7. Kamera hata hii. Ndio kuna moja. Lakini ile inapakia na kidogo. Okay. Kamera yako iko. Unaona ile ilikuwa huko ndio hii sasa. Yeye ndio utakatua nje kwa hapa kwa. Nenda. Basi ndio abiasa vitu kamera za hapa. Kwa sawa. Ndio abiasa wamechukua kamera tu warudi wafanye.
Oscar, come to the stage.